what I know you're interested in, which is your assessments. There they are up there. Just turn these lights down a bit. Is that better? Okay, so end of this term, 13th of May, you'll have a written exam, which is 25 picture-based questions. Here's a picture, here's a couple of questions about the image. And then you've got 20 MCQs. That's end of term. End of year, there'll be a clinical OSCE, as in there'll be an ophthalmology station in your OSCE, and then there'll be a written as well, which is one extended match question and then short answer questions. I don't know the dates of the end of year exams yet. You might already know them, but if you don't, they'll be confirmed soon enough. Supplementary exams, obviously none of you guys will need that, but if and when they're needed, they're usually in early to mid-January. Okay, so if you just make note of the end of term exam, if you didn't already know that. Let's start. Today's lecture will be about red eyes and red flags. This is the second part, if you like, of the red eyes lectures. Part one's already online. If you haven't had a chance to watch that, please do so. And between those two lectures, most of the red eye conditions will have been covered. Most, but not all. There are PowerPoint files on your LMS, which cover everything else that you need to know for the curriculum, as well as the other videos that we've got online. So everything is available there if it's not covered today. Resources include the first video, as I mentioned, which is on YouTube. And also there's a podcast which I did with a junior doctor on red eye, which is available on this MedTalk Pod website, which just talks about the approach to red eye. And that might be a useful sort of supplement when you're catching the bus to uni or whatever, to just go through red eye before your exams. Red eye is really common. You're going to see it in hospitals. You're going to see it as a GP. So it's important to have an approach to this stuff. So we'll go through that approach in a moment, and then I'll actually go through the conditions, infective and inflammatory conditions that we need you guys to know. We'll cover 10 conditions in total today. So there'll be some infective and inflammatory ones, and then some that don't quite fit into those infective and inflammatory categories. Here's the approach that I think is useful. So basically, patient walks in the door, you want to know if there's been trauma or not, because it's going to quickly send you down different pathways as to what the diagnosis might be. Diagnosis in red eye mostly comes from history. And for you guys, I want it to be intuitive. So even if you haven't memorized the whole curriculum, if you just think, is it trauma or is it not trauma? That's going to be in the trigger that we give you, or the patient's going to tell you in real life. If it's trauma, well, which structures are damaged? And if it's non-trauma, is it infection or inflammation? Or is it one of the other conditions that I'm going to talk about today? So this is your approach or your framework. The other framework is to go anatomical, front to back. So in the red text there are the conditions that affect each anatomical structure. So if someone comes in with a red eye, you should be able to think front to back, okay, what do I think is affected here? Well, the eye is red. So clearly something's going on in the conjunctiva, for example. But is there also inflammation in the anterior chamber, which we call uveitis? Is there stuff going on in the vitreous, which uveitis can also do? So you need to know your basic anatomy and have a front to back approach when you come to thinking about which structures are affected. Is that okay so far? Any questions? Good. So, all right. We've got the person in the room. We've got an idea of what it might be. Now we want to drill down and talk about your diagnosis and some reasonable differentials. Let's start off with this case. Here's a 7-8-year-old boy. He comes in, he's got periorbital swelling, I think you'll agree, particularly inferiorly, and his eyes look red. And in the close-up image there, I don't know how well you guys can, yeah, that's reasonable. Do you agree that the conjunctiva looks swollen? Yeah, So we call that chemosis, but you can just say the conjunctiva looks red and swollen. So he's got edema of the conjunctiva. It's bilateral, and he's presenting in springtime. And his mum says, you know, this seems to have happened the last couple of years around this time of year. So any thoughts as to what might be going on? That's a good thought. And what makes you say that? So she said allergic conjunctivitis. Yeah. So look, red and swollen conjunctiva bilaterally could also be infective conjunctivitis. But the key there in the trigger is it sounds like it's seasonal. And the other thing is he's got a bit of inflammation just under his nose there as well, if you look closely at the picture. So it looks like he's got rhinitis going on as well. And obviously you would take a history. This would be the first part of your OSCE. What further history would you like to take? So you're going to want to find out about hay fever type symptoms, eczema type symptoms. Does he have asthma? Is he atopic overall? Does he have infectious contacts? If you're worried about infection, you do need to think about infection. You don't rule that out straight away just because he presents in spring. Infective conjunctivitis presents in spring too. But this is the differential to infective conjunctivitis is allergic conjunctivitis, and they would be the two main causes of conjunctivitis out there. Infective conjunctivitis we covered in the first lecture, so I'm going to talk a bit more about allergic now. So there's a seasonality to it, and it does tend to be recurrent. Itchiness is more of a feature than with infective conjunctivitis, as are the systemic symptoms, so rhinitis, asthma, and so on. Some of the things I talked about. This is type 1 hypersensitivity to an allergen. Often it's pollen, can be grass. They're the two most common things. Can be dust mites. So you may or may not end up co-managing them with an allergy specialist. More often not, unless it's really severe. If it's really severe, then you sent them to an ophthalmologist, probably. And that's part of your management plan, okay? But your management plan as a non-ophthalmologist in ED or as a GP is, yeah, you confirm that they've got injection and chemosis, the history adds up, there's no infectious contacts. So you start off with lubricating drops and oral antihistamines, and, you know, pick an oral antihistamine that's non-drowsy. Loratadine is one. And then you can consider allergy testing if there's not already an established diagnosis. And if that's not enough, then you want to send them to us, and we can use topical antihistamines, mast cell stabilizers. And then if it's bad enough, we use topical steroid drops. So there's a sort of stepwise approach where we can escalate treatment as we need to. Allergic conjunctivitis can be really bad. It can be quite distressing and debilitating and can affect vision. So it does need to be managed properly. Okay, next case. Eyelids red and appears swollen. So we've got an erythematous swollen upper and lower eyelid. The eye itself may not be a little bit red. And in the close-up there, what you can see are these crusty deposits at the base of the eyelashes. Do you agree? Yeah. So does anyone know what this is called, this condition? No, so this is Blepharitis, okay? So Blepharitis is super common. Anybody who works as a GP will see this. It starts in around middle age. So it's middle-aged elderly patients who get this. And it's quite a complex condition where the oil glands on the eyelid margins are affected. They're the meibomian glands. So that the person ends up getting less oily secretion onto the surface of the eye, which makes the eye less comfortable. You don't have oil on the surface, it's not as smooth. If you don't have oil on the surface, the water on the surface of the eye then evaporates more quickly, right? So imagine you've got oil on top of water that prevents evaporation. You lose the oil, the water evaporates. And you get these crusty, this crusty buildup at the base of the eyelashes. And the bacteria that are proliferating there are inflammatory, are pro-inflammatory to the eyelid margin. So they cause that inflammation that you're seeing there in bad blepharitis. And they also contribute to the meibomian glands becoming blocked. So this is essentially, it's an inflammatory cycle where bacteria lead to meibomian gland dysfunction, which leads to dry eye symptoms. So blepharitis and dry eyes go together. Not usually a vision-threatening condition, but it can certainly contribute to problems with the cornea, which, if not treated properly, can go on to give you a bad corneal infection. Okay. So the top image there, you see how the eyelid margin is a little bit inflamed. You can see those telangiectatic vessels, and those lumpy sort of prominences, they're blocked meibomian glands. They should just be little dots or holes. So if you haven't had a chance already, look at one of your colleagues on a slit lamp, and you should be able to see their meibomian gland orifices. If you press on their eyelid, you should be able to see meibomian secretion coming out of the orifice like a clear sort of waxy secretion, okay, or oily, I should say, not waxy. In meibomian gland disease and blepharitis, those glands become blocked, hence the meibomian secretion can't come onto the surface of the eye. What you see in the bottom image there is little punctate erosions on the surface of the cornea. So that's fluorescein staining. And fluorescein staining should be more or less uniform across the surface of the cornea. But all those tiny little dots you can see are microscopic areas of damage to the epithelium, the outermost layer of the cornea. So if you saw this in an endoscopy, you'd say, oh, the meibomian gland orifices look blocked to me, and there's little punctate erosions or tiny areas of damage. You don't have to use the perfect terminology. You just need to recognize that it's not normal, okay? This looks like dry eye caused by meibomian gland disease and blepharitis. So what are the clues in the history? Middle-aged to elderly patient, chronic and bilateral. Chronic and bilateral. The symptoms are grittiness. Oh, my eye feels scratchy, and watering. If you don't have enough oil, you produce too much water. That's why the eye waters in blepharitis. And because the tear film on the surface of the eye has been disrupted, then the vision intermittently can be blurry. Blink a few times, the vision gets better, you've restored the tear film. But if you're reading or watching TV or driving, the eyes dry out. And so intermittent blurring of vision is a clue in the history. Not many things cause that, but dry eye does. Etiology we've talked about. Examination findings we've talked about. So you're looking for those dandruff-like flakes on the eyelashes and the blocked meibomian glands. Management-wise, there are a few things. So the first one is what we call lid hygiene, where the person uses a cotton tip, sterile cotton tip, dipped in boiled water to scrub their eyelashes. Okay, a bit like brushing your teeth, but they're scrubbing along where their eyelashes are. And they need to be doing that every day. In the water, we tell people to use either bicarb soda or Johnson & Johnson baby shampoo, both of which should not be too irritating to the eye. So that becomes part of their normal routine. Warm compresses means you take a warm flannel or you use a flannel in a warm shower and you massage the eyelid margin, again, where the eyelashes are sprouting out, to try and mechanically and thermally push some of that meibomian secretion out. So you've got oil glands which have become blocked. You're trying to warm up the oil and mechanically push it out or unblock it. And you can also do that on a slit lamp as a doctor. You can see a blocked meibomian gland. It's a bit like an old tube of toothpaste. If you squeeze it hard enough, you can eventually get the toothpaste to come out, but you need a slit lamp for that. So that's really something that probably we're going to do more than GPs. And then lubricating eye drops are really important. There's a whole host of them. You don't need to know all of them. You just need to know that people with blepharitis and dry eyes need at least one moisturizing eye drop, if not two, if not one or two plus a cream to use at nighttime, because eyes tend to dry out more overnight. There's some evidence for omega-3 fatty acids. So they can be taken as supplements, or you can just eat oily fish. or nuts, which contain those. And there's some evidence for those helping meibomian gland secretion. And then we also have lots of options available to us in ophthalmology. So if you've got a severe case where you've tried these basic things, lid hygiene, massage, topical moisturizing drops, and you're not winning enough, then you refer them to us. We can use different topical agents. We can use oral agents, sometimes oral antibiotics. And there's other devices, thermal pulsation and other equipment that we sometimes use to help dry eye syndrome. Topical antibiotics and steroids can have a role, but they definitely should not be your first line treatment. Don't have a knee jerk to go to antibiotics or steroids if it looks like blepharitis. And your challenge is going to be to differentiate blepharitis in real life. The challenge is this blepharitis or is this conjunctivitis? So just remember, blepharitis, chronic, grumbling, ongoing, older patient. Conjunctivitis, acute, eyes more red, more discharge, possibly infectious contacts, possibly a preceding upper respiratory tract infection. So the skill there is to differentiate between those two and don't knee-jerk to caloric drops, okay? Discuss it with one of us if you're unsure. All right, next condition. We've got a lump on the upper outer aspect of the upper eyelid and then a similar but different looking lump on the bottom lid. The image on your left is what we call a Clasian. So we've talked about meibomian gland secretion. Clasian is trapped meibomian gland secretion that has enlarged over time and inflamed the tissue around it. The other image, which looks a little bit more like a pimple because it looks like it's got a little pointing head of pus, that's an infected eyelash follicle, which we call a stye. So in the community, people will call both of these things a stye, but it is important to differentiate one from the other because the treatment's different, as I'll talk about in a moment. So one's inflammatory, Clasian, one's infective, stye, okay? And on these images, the top one's a Clasian, the bottom one again, you've got that pointy little, looks like a pimple, that's a stye. History-wise, both tend to be subacute, days to weeks, and usually they're mildly painful. This isn't like a severely painful presentation. Etiology-wise, as I said, Clasian inflammatory stye infected, usually staph species. And Clasian-wise, Clasians tend to be bigger, the inflammation tends to be bigger, and it's within the sort of body of the eyelid, if you like, which is where what we call the tarsal plate is, which is like, sort of like a cartilaginous or connective tissue plate within the eyelid. The stye tends to be more at the eyelid margin where the eyelashes are. So not so much within the body of the lid, but more at the root of an eyelash or some eyelashes. So if you think you've got a stye, you want to remove the lash that's infected, and that'll give the pus, which is what that white stuff is, a channel to exit. And then warm compress, topical antibiotic ointment, Chlorcig is good, okay, to prevent infection getting worse. If you've got a Clasian, it's warm compress again to try and mobilize that meibomian secretion, but we're not going to use antibiotics, you're not plucking eyelashes, and you're just going to give them time. Both of these need time, but particularly Clasians. With either one, if it's not getting better with time, so as GP, you see them again in a week or 2 weeks. This is what I would recommend. They tend to get worse before they get better. But if you're concerned, then obviously you refer. The thing to watch out for is associated cellulitis, true associated cellulitis, where you've got quite a lot of redness of the whole lid. So it's not limited to just, you know, where you think the Clasian or the stye is, but it is extending up as far as, say, the eyebrow or down below the ridge of the zygoma, you know, your cheekbone. And so if it looks truly infected, that is starting on oral antibiotics and or referring if you're worried. That's uncommon, okay? Far, far more common is it's just a stye, it's just a Clasian, right? If a Clasian is persistent, regardless of warm massage time, fish oil supplements, etc., if you're left with a hard lump there, then we incise and curette those under local anaesthetic as an outpatient procedure. So we tend to not do it when the Clasian's hot. You know, acutely inflamed Clasian, it's usually not a great time to incise them. You want to wait for the meibomian secretion to collect. That takes weeks. Once that's done, then we can incise and curette one. I did one on Friday on a friend of mine. So, you know, they're pretty common. I did one on a med student once in Albany. And when they're really well collected, it's very satisfying. It's a bit like, you know, a massive pimple or a, you know, almost like delivering a baby sometimes, if it's a really big Clasian. So usually not a threat to vision, but watch out for cellulitis. Okay. Okay, moving on. Clearly we have a red eye and it looks pretty bad, but what I want you to appreciate with these pictures is that the redness appears to be localized more to one part of the eye, with the rest of the conjunctiva being less red or being completely normal, right? So in the image on your right, you can see that the conjunctiva in the affected area actually looks a little bit raised or nodular. That's important. That nodular swelling looks important. And it's relatively sectoral. It's one area that's red. In the other one, the whole eye looks red, but definitely the lateral aspect, the outermost part, is more red. So sectoral injection or sectoral redness of the eye, I want you to think of two main conditions. One is episcleritis and one is scleritis. They're both usually inflammatory, sometimes infective. One affects the sclera, you know, the white connective tissue, hard shell of the eye. One affects the episclera, which is a thinner tissue on top of that. They present quite differently. Episcleritis tends to be mildly uncomfortable. Scleritis tends to be severely painful. So scleritis is probably one of the most painful eye conditions that we see, along with a handful of others. So your trigger in an OSCE, your trigger in real life is severe pain, bad enough to take the patient up at nighttime, and sectoral redness. If you see those or hear those in the trigger, then you're thinking scleritis. If it's mildly uncomfortable but sectoral redness, then you're thinking episcleritis. Onset-wise, these are subacute, hours to days. Let's focus on scleritis, so severe pain. And the images that we've got there are more examples of the same. Scleritis can definitely affect vision because there can be associated inflammation within the eye, okay? So anterior or even posterior uveitis. And it's called a, you know, the buzzwords are deep and boring pain, as in it's boring into your head, drilling into your head. Most commonly, scleritis is either idiopathic or linked with collagen vascular disorders, rheumatoid or SLE or ankylosing spondylitis, something like that, but they can be infectious as well. So they're the systemic symptoms that you have to ask about in your history. So you've done your ocular history and then you want to say, do you have any joint problems? Do you take any medications for other joint or connective tissue or skin issues? That's the sort of systemic history you want to be taking. And then examination-wise, with scleritis, you're looking for vasodilation, or, you know, we call it injection, red inflamed blood vessels that are deeper than the conjunctiva. Now, what's the diagnostic test for telling whether they're deep to the conjunctiva or not? The conjunctiva is the most superficial part. Those vessels will be injected or inflamed as well. The diagnostic test is to put on a drop of phenylephrine, which all eye clinics and emergency departments will have. And due to the action of the phenylephrine, the conjunctival vessels will constrict. So the conjunctival redness will go away, but the deep scleral redness will stay. If the eye becomes white 5 or 10 minutes after you've put in phenylephrine, that's either episcleritis or conjunctivitis, right? If the eye stays red, that's scleritis. So that's your diagnostic test. Know that when you put in phenylephrine, the pupil is also going to dilate. So you want to tell the patient, hey, your eye's going to become even more blurry because we're just about to dilate it. And dilation is good because then you can do fundoscopy. So as long as they're not driving, that's okay. The image on the bottom there shows parts of the sclera that have become necrosed in a chronic scleritis case. So you see how there's some dark patches there under the conjunctivitis? That's where the sclera has become so thin that you're looking at internal tissue in the eye, which is the choroid, which is a vascular, pigmented vascular layer inside the eye. So the sclera can become so thin that it can actually perforate, or you can virtually transparently see tissue inside the eye. That's a sign of chronic recurrent scleritis, and it is a clue in an acute case that, hey, this is scleritis. Look, the sclera is so thin. I think they've had this before. Management-wise, most cases of scleritis, you can get away with high-dose oral non-steroidals for a period of time. Make sure they're not allergic to non-steroidals. Allergy to non-steroids, I have found out recently, is very common because I had an allergic reaction to Nurofen, believe it or not. Has anyone had an allergic reaction to Nurofen or aspirin in the room? No, lucky. It's terrible. So ask whether they're allergic before you dose them up. And then scleritis is a definite referral to us. We need to see them same day, next day. This is not one you leave for days or weeks because it can be blinding. You know, it can extend posteriorly, it can affect the optic nerve and the retina. So we'll add topical or systemic steroids if it's needed. And longer term, they may need systemic immunosuppression and co-management with rheumatology if they're not already seeing a rheumatologist. So scleritis, uncommon, but definitely serious. And the main differential is episcleritis. Okay, here's something that tends to happen in younger people. So top image, we've got swelling around baby's left eye. And bottom image similar in an older patient, a bit more inflammation or erythema in the bottom image. So when you see pictures like this, okay, conjunctivitis can do this. Conjunctivitis can give you periorbital edema and redness. But normally the eye's red, the eye's not red in these images. So conjunctivitis, you have to have a red eye. That's where it starts. Conjunctivitis usually bilateral. So this is clearly unilateral, okay? Therefore, the next most likely thing is what we call periorbital cellulitis, which is normally infective. And as the name suggests, it's infection of the skin around the periorbita, you know, the eyelid and the eye socket. Quite common actually in kids, you know, in our pediatrics terms, we'd see this every week. Often associated with an upper respiratory tract infection, sometimes with sinusitis. And the ones with sinusitis, you've got to be a bit careful because they can get bad pretty quickly. The absence of the red eye is important to differentiate it from orbital cellulitis, which I'll talk about a bit later. So let's talk about periorbital, or we call it preceptal cellulitis. Now, bit of anatomy, which is important to understand, okay? So what separates the eye socket, here's the contents of the eye socket, okay, around the eye. And then here's the eyelids, top and bottom at the front. What separates eye socket contents from what we call the anterior lamella, or the eyelids and eyelashes, is a layer of quite thin connective tissue called the orbital septum. Okay, so you think of this as a connective tissue curtain behind the eyelids that separates eyelids from eye socket contents. We call the eye socket the orbit. Okay, so orbital contents, orbital septum, eyelids and soft tissues at the front of the eye. Preceptal cellulitis, as the name suggests, is infection or inflammation of the eyelids, skin, basically. Okay, so eyelids and periorbital skin. Preceptal. Preceptal, certainly annoying, but on its own, not a threat to vision. Postseptal, so behind the septum, that's true orbital cellulitis. So as I say, I'll talk about that in a moment. Orbital cellulitis is a threat to sight and life, potentially. That's a big red flag condition. Let's focus on preceptal. And preceptal can become postseptal, right? So periorbital can become orbital. So very important to get this right. So both are subacute. And preceptal tends to be younger years, tends to be unilateral. We've talked about etiology. Usually it's staph or strep species. Often in kids, there'll be an insect bite or a scratch that's caused the infection, some sort of trauma. And examination-wise, the main thing is the eye is white. The vision, if you can measure it, should be normal or close to normal. EOM is external eye movements, okay? Or ocular motility is what we call that. So you want to check eye movements, and in preceptal cellulitis, eye movements are normal. In orbital cellulitis, eye movements can be affected because the whole orbit, including the muscles that move the eye, are infected and edematous, and they're not working properly. So normal vision, white eye, normal eye movements, the eye isn't proptosed, the whole eyeball isn't sticking out. In a nutshell, the eyeball is not affected, it's just the eyelids. And systemically, they're well. There's no reason for them to be systemically unwell. So oral antibiotics management-wise is usually enough for these guys, Augmentin or Cefalexin. And follow them up closely. You know, this is a common GP presentation because you want to make sure it's getting better, not worse. If they get worse, then they need admission for IVABs and so on. If you or us are worried, we're going to think about a CT head, but we're not going to undertake that lightly in a kid because they're getting irradiated. So we avoid the CT if we can, try and make a clinical diagnosis. You can do a cutaneous swab if there's a wound to get a microbial diagnosis. Full blood count if you're not sure whether they're systemically unwell or not. But the mainstay of treatment is oral antibiotics. Another really practical thing you can do is get a skin pen. You know, we have these skin pens in medicine, which you can wash off and just mark out the edge of the cellulitis or the inflammation. So we do this for patients who are admitted so that when you see them the next day, you can tell whether it's gone beyond that margin or whether it's retracted. And it's a good marker for mum and dad as well to be able to get in touch or to present to emergency if they're worried. So preceptal common, it's hard to say not serious because it can become very, very serious, but on its own, not dangerous. Now, before we move on to orbital cellulitis, I want to show you something that can be confused with preceptal cellulitis, okay? The difference here is the obvious difference. And look, in your OSCEs, guys, and in real life, often we'll show you an image. You don't have to be technical with how you describe it. Trust your instincts and just go to the obvious abnormality. Makes everyone's lives easier. So you say, oh, look, the obvious abnormality is there's a big red swelling near the nose, near the junction of the eye and the nose. That's enough. That's all you have to say. And so this is what we call Dacrocystitis, this condition, right? So if you see red, tender looking swelling, roundish shape, which is acute in onset, so you know it's not going to be a tumor, right? Acute onset, patient's kind of unwell. You're going to go, well, this looks a lot like the preceptal cellulitis that we talked about in our lecture, but also there's this big round lump. And I want you to know that underneath that lump is a structure called the lacrimal sac, which is what collects the tears in your eyes. So you're constantly producing tears. They drain into a little sac, which then drains into your nose via another duct, okay, nasolacrimal duct. If that sac gets blocked, then it's a fantastic environment for bacteria to proliferate. So a blocked lacrimal sac leads to Dacrocystitis, which is what this condition is called. These patients will be unwell, unhappy. Pretty much this needs a hospital admission. So there's an image there on the top of the relevant anatomy, and These are called the Canaliculi. They drain the tears, top and bottom, into the lacrimal sac, which then drains into the duct and then into the nose. This is just a close-up of the same structures. There's the lacrimal sac there. You've got a blockage somewhere in here, leads to infection of the lacrimal sac. So medial canthus is what we call this area, if you want to use ophthalmology jargon. You've got painful red swelling, and you can have discharge as well because there's pus in there, and it can be discharging out onto the surface of the eye. If you're brave enough to push onto the swelling, which you may get away with in an adult, you'll express some of that stuff, which you can then use for a swab. You should be able to do that with a kid as well. That's useful to get a swab done. And so common in kids, and then common later in life, over 40-year-olds, okay? People 20 to 40 don't seem to get it as much. So either the kid has been born with some lacrimal sac problem, which eventually turns into Dacrocystitis, or later on in life, you've got a mucus plug for some reason in an older person blocking the lacrimal sac. And the offending agents are the usual suspects: staph, strep, pneumococcus, or Pseudomonas. So you start off with a nice, broad spectrum antibiotic. Then we can get a diagnosis, get sensitivities, and so on. Examination we've talked about. Now I'm saying normal, normal extraocular movements and white eye. But again, Dacrocystitis can become orbital cellulitis. So if the eyeball is red, then pretty much that person is going to need a CT scan. Okay. Maybe not in every case, but it's an important thing to look for on examination and to mention as a negative in your OSCE. Oh, look, the lid's swollen. I think the lacrimal sac's involved. The eye appears white. I'd like to test. We always test visual acuity. So that's the first thing you're going to say. I also want to test ocular motility to see if eye movements are normal, because I'm worried about I'm always worried about orbital cellulitis in these cases. And you go tick, 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 tick on your marking sheet. Refer these guys to ophthalmology. So this isn't something to just manage on your own, but you can certainly do a swab. You can certainly do some bloods, and you can discuss doing a CT scan with us. You can start antibiotics, in consultation with us. And the definitive management in many of them ends up being surgery. So dacrocystorhinostomy, you don't need to know what that is, but in a nutshell, it's creating a new passage where the passage has become blocked. Nasolacrimal duct obstruction, NLDO. That's what we're trying to unblock with DCR surgery. So you get them over the acute episode, keep them safe, and then they need surgery. And as I mentioned, beware extension to true orbital cellulitis. Preceptor cellulitis, Dacrocystitis, and orbital cellulitis are part of a spectrum. So when you think of one, think of the others, okay? All right, so we're moving on to orbital cellulitis, and particularly in the image on the bottom, I think you'll agree with me, this looks really bad. And if you look closely at the image on the top, okay, let's say this is your OSCE. I want you to say the right eye, or the skin around the eye, the top and bottom eyelid are clearly red and inflamed. That's the most obvious abnormality. Now, let's look a little bit closer. From what you can see of the right eyeball, it actually is a little bit lower down than the left eyeball. It's depressed inferiorly. And whilst the left eye is looking straight at the camera, the right eye is actually turned down and a little bit out. Okay. Now, when we say down and out, we're normally talking about a third nerve palsy. Ignore that, because third nerve palsy doesn't come with orbital cellulitis usually. I just mean that the eyes aren't looking in the same direction, which tells you that there's a problem with the extraocular muscles. Something's going on behind the eyelids, right? So without doing a CT scan, you'd have a very high suspicion that that top image is orbital cellulitis, not just preceptal cellulitis. And what you do on examination is just gently prise open the lids and look for conjunctival redness, okay? And don't be surprised if it's there. Now, you can have orbital cellulitis and still have a white eye, but the other clues in this person is the whole eyeball is displaced. So you're worried about a superior collection in the orbit, okay? And it appears to be turned out. So you're worried about extraocular muscle involvement. The one on the bottom, you can't even see the eyeball. That's how swollen it is. And in a kid, can be very hard to examine them. We have our ways in ophthalmology to try and sneak a look at the eye, but ultimately, many of these guys are going to need neuroimaging. So there's another really obvious example. The top image there, the eye is looking upwards, I think you'll agree, whereas the left eye is looking straight at the camera. Both eyes are dilated. And that person's actually had surgery. You can see they've got, if you look closely, they've got sutures there in their upper eyelid. Lots of redness, lots of swelling. All the conjunctival is red. This is sort of barn door orbital cellulitis, okay? The middle image there is a CT, and you've got what I want you guys to be able to identify is firstly that this is the left eye. Remember, with this imaging, it's as if you're looking at the patient as they're lying down from their feet upwards. So there's a person looking upwards. This is their left eye. And here's a clear sphenoidal sinus here, and the ethmoid's here. And these sinuses are full of mucus and infection. And you've actually got what appears to be a fracture here. Or it could be a subperiosteal abscess, and it's just on the cut, it looks like there's a fracture. The history will tell you that, okay? So history is, was there a motor vehicle accident? Was there a punch injury? Is there a reason for there to be a fracture? The key thing here is that the sinus is infected, and that's the most common site of origin for orbital cellulitis, is bad preceding sinusitis. So the history is, oh, look, I had the sinus infection and we started all our antibiotics and it's just gotten worse and worse and worse. Now I'm in excruciating pain, okay? Usually unilateral. Look, the other thing with this one is, there's a red flag at the bottom. The other thing with this one is that the whole globe is displaced laterally, you'll agree, and forwards. So clinically, this person would present with really bad proptosis and displacement of the eyeball. So unilateral, person's unwell. Okay, more unwell than Dacrocystitis, definitely more unwell than preceptor cellulitis. More common in immunocompromised patients, so diabetes or HIV or other immunocompromise, and extremes of age, so kids and older people. So elderly is what I mean, not so much middle age. And etiology-wise, we've talked about staph and strep spread from local structures, whether it's sinuses, teeth, skin, something on the eyelid, okay? Examination-wise, make sure you ask about, in history, make sure you ask about systemic. This goes in general, actually, for your OSCEs. Often in an OSCE, you'll just forget to ask about systemic symptoms, and you'll miss points in your in your history section. So remember, always think eyeball and then systemic. Examination-wise, we've talked about most of this. Yeah, if there's reduced vision, if there's a relative afferent pupillary defect, if there's limited extraocular movements, that's all bad, bad, bad. Okay? That's all orbital, postseptal rather than preceptal. Management-wise, look, orbital cellulitis can be a threat to life. So this is immediate IV antibiotics, immediate neuroimaging. Start the IV antibiotics first before you get neuroimaging. You can get subperiosteal or intracranial abscesses even, can extend to meningitis. Ophthalmology and ENT will be your most common consults, and one of us will admit them and possibly take them to theatre if we need to drain an abscess. IV antibiotics, and then wound swabs and blood cultures we've talked about. Okay, so again, preceptal, postseptal, and Dacrocystitis, part of a spectrum. Clump them into one entity in your head, and that's how we've organised the curriculum as well. All right. Okay, we're making good headway. Any questions so far about has anyone seen a case of orbital cellulitis? Oh, wow, okay. Recently or in previous years? Mm-hmm. Wow. How old? And so he was admitted for something else, presumably. And his eye or his eye socket was slowly becoming more and more red whilst he was admitted. Is that what happened during the admission? Yeah, see, eyes get missed. Eyes get missed because people are scared of eyes or don't know about eyes. They just don't think about it as part of their whole workup. So did you see him in an ophthalmology clinic? Oh, okay, just recently, hey? So he was getting IV antibiotics. Was the etiology thought to be systemic? Like, was it related to his initial admission? Or were they not? Did he have sinusitis or not sure? He was already on antibiotics, so he was septic probably for some other reason, UTI or something, and then, yeah, there you go. Yep. All risk factor, all predisposing. That could be an OSCE. There you go. Was he getting better? Ooh, okay, there you go. That's a really good. I mean, it's terrible for him, but it's good learning for the rest of you. So he would have had panophthalmitis, okay? So that's when it's not just eye socket, but it's the whole eyeball, the whole contents. And that's pretty uncommon. That's bad luck. As an intern, I saw someone die from orbital cellulitis. So elderly lady, immunocompromised. She had fungal orbital cellulitis. She was going to die anyway, probably. But yeah, it's just a big fat red flag. And most of the time that doesn't happen. It's very unfortunate for that man. Okay, so early detection and early suspicion is important. All right, moving on to another serious condition. So the obvious thing I want you to see here is what we call a hypopian. A hypopian is a pus fluid level in the anterior chamber, okay? So you're seeing a sort of crescent-shaped white collection in the anterior chamber, and that's a collection of white blood cells or pus in the anterior chamber. It's either going to be infective or inflammatory. I'm going to talk about the infective one, and the most common inciting incident here, right, the most common cause will be a recent procedure. That's the most common cause of what we call endophthalmitis, which is what this is, all right? So on your trigger or in real life, they're going to say, I had an injection into my eye 3 days ago, 4 days ago, or less commonly, I had cataract surgery 3 or 4 days ago. By far the most common cause of this these days is injections into the eye, because that's a really common procedure where there's potential inoculation with bacteria, okay? And you end up with very red, very painful, vision down, hypopian. They're the main signs. And if you look on the slit lamp closely, the anterior chamber will be full of cells. So you need to know how to look for cells in the anterior chamber as part of your clinical skills. So history-wise, hours to days, severe pain. This is a red flag condition as well, quickly blinds people. Recent injection or surgery, as I say, usually iatrogenic, gram-positive. And examination-wise, the key thing is your hypopian. So the history plus hypopian, you're thinking endophthalmitis. Urgent, same-day ophthalmology, not next day. Yeah, same hour, if you can manage that, because we're going to want to inject some antibiotics into the eyeball ASAP, if not take them to theatre to do what's called a vitrectomy, where we remove the vitreous gel, the vitreous gel in the back of the eye. So we're not removing the eye, but we remove the vitreous, so we remove most of the bacterial load, inject some antibiotics in there, possibly inject some steroids in there. And the sooner they get a vitrectomy often, the better they do. As far as you're concerned, fast them. So recognize it, talk to one of us, fast them. We may or may not ask you to start systemic antibiotics. Different hospitals will have different approaches to that. And Patient's going to go, doctor, what are the ophthalmologist going to do to me? You tell them they're going to make your eye numb. They're going to remove some of the fluid from inside the eye, send that to a lab so they can figure out what bug is causing this. And they're going to inject some antibiotics into your eyes. And they can do that in the clinic. Later, whether it's same day or same week, they may take you to theatre to have an operation. Okay. So that's the level of information that you need to know for your OSCE and for real life. Okay. Urgent referral, intravitreal tap and antibiotics, plus or minus theatre. And, you know, if they're picked up and treated early enough, they can do well. If they're not, this is devastating. This is definitely loss of sight if it's not picked up early enough. Every 5,000 injections or so worldwide, you'll get one case of endophthalmitis. So, you know, there's tens of thousands of injections happening in Australia every month. So this is not uncommon in an ophthalmology department. All right, getting towards the end, guys. So we've talked about infective and inflammatory causes. I'm going to talk about, I think it's two conditions now which don't really fit into either of those. The first one's a pterygium. You might have seen these already in eye clinics. Some of you might have a pterygium. They're quite common in Australia. This is a fibrovascular growth of conjunctiva across the surface of the cornea. The examples here are really big and obvious. Often they're smaller than this. Common in Australia because we've got a lot of UV exposure, which is the most common risk factor for pterygium. So it can be unilateral or bilateral. You can call it a growth. It's not a tumor. They can definitely be red eye and uncomfortable, but not severe discomfort and not acute. Okay. So they clearly should differentiate it from all your other red eye causes. Oh, it's been there for years. Not even months, but years. Okay. The etiology is actually degenerative. So you get elastotic degeneration caused by UV exposure. You can get an associated cancer, squamous cell carcinoma or something else. That's a tissue diagnosis for us to make. If we're suspicious, we'll send the pterygium off to the lab. And examination-wise, you've seen the pictures, you get a triangular sheet of fibrovascular tissue. Usually it's nasal, can be temporal, can be both. But by far the most common is nasal. Management-wise, so this is a GP presentation, not an ED presentation. You just start off with UV protection, good sunglasses, and moisturizing eye drops. Most pterygiums can be managed that way. Yep, the growth will still be there, but not too uncomfortable, so the person can live with it. If it's rapidly growing, so by rapid, I mean weeks to months, oh, it's been there for a while, but it suddenly got worse. That's a quick referral to us. That sounds like cancer to me. And then indications for surgery, you need to know what these are. Why would you operate on this? If it's really uncomfortable, if it's starting to affect vision, either by growing across the pupil or by exerting traction on the cornea, so they can actually sort of pull on the cornea, distort the shape of the cornea and induce what we call astigmatism, which means an irregular shaped cornea. That'll affect vision. So it's affecting vision, it's threatening the center of the pupil, it's really uncomfortable, or the person just doesn't like the look of it. So if it's sounding like any of those things, then it's a referral to us, or if it's quick growth, then definitely a phone call to one of us. Pterygium, super common. You will see this as GPs, so you need to know how to manage it. All right. These pictures probably don't tell you a great deal other than the eye's red, and in the image on your left, your right, image on your right, the cornea looks a bit cloudy, and the pupil in both of them looks a bit bigger than average. Now, if I tell you that the person hasn't been dilated by us, you can then tell me we've got a red eye, we've got corneal clouding or corneal edema, and we've got a mid-dilated pupil. It's not massively dilated, it's mid-dilated. Those three signs, in conjunction with the right history, are your triggers for acute angle closure glaucoma. Acute, okay? So chronic glaucoma and acute glaucoma are completely different beasts in a sense. They're the same in that both of them end up with optic nerve damage, but they present completely differently. Chronic glaucoma is most of the time asymptomatic. Okay, person doesn't even know they've got it. Acute glaucoma, very symptomatic, severe pain, one of the most painful eye conditions once again, up there with endophthalmitis and orbital cellulitis. They don't get proptosis, they don't get all of that stuff, but they get a very red eye, severe pain, 8 to 10 out of 10 type of pain, vision affected. And then as far as ocular signs, yeah, injection, mid-dilated and sluggish pupil, not necessarily completely unresponsive, but sluggish, and corneal edema. That's a sort of triad of signs. Angle closure, not rare. I wouldn't say it's common, but it's not rare, okay? So what happens in angle closure? Let's talk about the etiology. Here's the normal fluid dynamics of the front part of the eye in this image, okay? So aqueous humor gets made by the ciliary body, which is next to the lens in the eye. Fluid travels anteriorly, goes through the pupil into the anterior chamber and drains out of what we call the angle into something called the trabecular meshwork, which is at the junction of the iris, here's the iris, the colored part of the front of the eye, and the cornea. So in there is where fluid normally drains. In angle closure, for various reasons, fluid can't get out because of what we call pupil block. Pupil block. The iris is sitting on top of the lens. The fluid's got nowhere to go. Therefore, it builds up in this space. The iris bulges forward as a result, which further blocks off the angle. So this is increasing the pressure. Then this fluid can't leave, so the pressure goes up even more. So, and you can see this pupil billowing forward on a slit lamp, okay? You can see it sort of puffed forward. So where normal pressure in the eye is, let's say 10 to 21, that's a normal range that we give. Angle closure glaucoma, true angle closure tends to be 50 plus or unrecordable. So you got to record the vision, you can't even, machine doesn't give you anything. When you're in emergency, the main thing on presentation though is pain. So this is a really unhappy, sick person. They may be vomiting, that's how bad the pain can be. The onset is hours, typically. It's not days, it's hours. And it's often later in the day when the pupil's starting to constrict, right? Pupil constricts, which means the iris is moving this way, making it more likely to sit on top of the lens and cause pupil block. If the iris is retracted and widely dilated, you've got more of an avenue there for fluid to move out. More common in Southeast Asian patients because of eyeball anatomy, okay? So the typical trigger in your OSCE will be, and more common in women, and it's almost always 40-plus-year-olds. So it's a disease of middle and older age. Kids don't get acute angle closure glaucoma, not from pupil block anyway. So your trigger is going to be 55-year-old Cambodian female with acute onset, severely painful, unilateral red eye. So you have to say acute angle closure. That's by far going to be the most likely condition, okay? We've talked about the etiology. Yeah, examination-wise, intraocular pressure is important. So you or someone in the department who knows how to measure IOP does that. Make sure you anesthetize the eye before you check pressure. And an even simpler way is just get the person to close their eyes and very gently, you can digitally just palpate, okay? And an angle closure, you should be able to feel that one eye feels rock hard in comparison to the other eye. Normal eye you can press on, not too uncomfortable, right? Don't go poking someone with angle closure, they're already in pain. But if you don't have a tonometer in your clinic, then that's a basic way of assessing pressure. We've talked about the examination. Look, shallow anterior chamber, that's part of the anatomy, which predisposes, if you're shallow here, if this angle is smaller, then it's going to be easier to close that off. You should be able to see that on a slit lamp, but it's probably more of an advanced examination finding, but you can mention it in an OSCE setting. Oh, look, I'd want to take a closer look at the anterior chamber depth. Well, how do you know what a normal anterior chamber depth is? I'd look at someone else in the department. I'd look at a colleague, have a look at their anterior chamber, and do a gross comparison to what this person looks like. That's the only way you're really going to tell. There's ways of grading anterior chamber depth. You guys don't need to know that. Management-wise, again, there's a trend here in this talk. This is an urgent referral to us, urgent discussion. Pick up the phone, talk to us, because we can start stuff over the phone, topically and orally. And orally, we use acetazolamide, which is a carbonic anhydrase inhibitor used by neurologists for other things. And that reduces aqueous production. So we'll start on a fairly high dose, as long as they don't have a sulfur allergy, so you have to check for that. So systemic acetazolamide can be given IV or orally. And then topical pressure lowering drops. Timolol is one. It's good to know the names of one or two. That's a beta blocker. There's 4 classes of topical pressure lowering drops. We'll use at least 3 classes usually in a case of acute angle closure. The definitive treatment is to shoot a hole into the iris, which is called a peripheral iridotomy. Peripheral because it's not towards the middle of the iris. Iridotomy, hole through the iris using a laser. And what that does is, if you've got a blocked channel here, we'll just shoot this open and create a bypass. And that gives immediate relief. But the cornea needs to be clear enough for us to do the laser. So often it happens not on admission, but the next day or the day after that, once we've got the pressure down and the corneal swelling is reduced. So a patient says, doctor, what are they going to do to me? They're going to admit you. They're going to keep giving you all these drops. They're going to continue this tablet that we're starting now. And they're going to do some laser treatment to create a bypass for this high pressure in your eye. If they're caught early, acute angle closure does well. We may do a prophylactic peripheral iridotomy in the other eye, because if they've had it in one eye, then they're at risk in the other eye as well. Okay. Every case that I've shown you today, a patient comes to mind when I was a junior doctor. And the person that comes to mind with this one is an elderly lady in an emergency department in the UK, actually, where I was at the time, who was in a bed vomiting and needed opioid analgesia. That's how bad it was. Okay. Typical presentation: female, older, severe pain, etc. Okay, so guys, they're all the conditions covered. Just a few tips for OSCEs and real life. Often in an OSCE, when a patient presents with pain, we'll go, what do you guys want to do? You say a bunch of eye stuff, and you'll forget simple oral analgesia. Almost everything that I've talked about today needs simple oral analgesia. Don't forget that. It's common sense. It will get you a point in an OSCE, and it's cruel if you don't do it in real life. So do think about it. A couple of do not do's. One is never discharge a patient with topical anesthetic drops to go home. Okay, if someone's got a corneal abrasion, when you examine them, you put in a topical anesthetic drop, they will love you and they'll say, can I take those drops home? If people keep taking topical anesthetic drops for a while, they're actually toxic to the corneal surface, will worsen the abrasion and help and bring on an infection. So unfortunately, I had to fail a student once who had passed the OSCE, and the last thing he said was, I'm going to discharge them with topical anesthetic drops. And that's an automatic fail. So, because that's a threat to sight. So you never do that. In real life, we do sometimes do that. If someone presents at 3 a.m. and we just need to get them through to the morning where they can be seen in an ophthalmology clinic, we can do that. And we may say that to you over the phone, but never unilaterally make that decision. Similarly, never unilaterally make the decision to start topical steroid drops, because topical steroids are for inflammation. It might be infection. If it's an infection, the steroid will mask the infection symptoms because it's going to reduce the inflammation. But the microbe, whatever it is, whether it's a bacteria or a steroid, is going to love the steroid. And the infection is going to explode out of control, even if the patient's more comfortable. So particularly for viral keratitis, which is usually herpes, okay, herpes simplex keratitis, which I may have covered in the other red eye talk, I can't remember. That's when you get a dendritic ulcer on the surface of the eye. And it's easy to miss a small dendritic ulcer. So whatever the case is, don't start steroids, don't start anesthetic drops unless you've discussed them with us. Okay, so there are the 10 conditions that we've covered today. There's the approach to the red eye that I want you guys to have. Is it trauma? Is it not trauma? And today we've covered infected, well, everything that's non-traumatic, essentially. So thanks for listening.